So just at a high-level overview, the robustness of this data is pretty impressive. When you think about this test, it's been evaluated in a variety of different trials. So when we look at the data collectively, there's over 4,500 patients in which this assay has been evaluated. And each of these trials are different. You know, you can see real quickly there that the design of who was incorporated into these studies, very different, very heterogeneous, but it's the consistency of the finding that gives us faith in that this is a real finding. And that you see when you look at the high predictive score, as you go across for all those trials, it's locked in right around a 2/3 relative risk reduction compared to the placebo arms or the control arms in these study. It's that consistency that's really impressive for me. But also on the other end of the spectrum, when you have an H/I low score or no assay, no answer on the assay, you again can see there's no benefit for those groups, and that's a very consistent finding. So today what I'm going to do is really kind of dig down on a handful of these trials so you can see operationally how this data plays out in these studies. First, I'll start with MA17. This really got the ball running. Just to remind everybody, MA17 was a trial that looked at patients who had been on tamoxifen in the adjuvant setting after a small washout period of roughly 3 months, and they were randomized to proceed with an aromatase inhibitor versus placebo for 5 full years. In the parent study, this was a positive trial with a roughly 4 or 5% benefit for that extension of therapy. In the validation study related to the BCI, they were able to capture 250 blocks or so. Again, you can see the randomization schema that was applied to those patients. And for the parent study, like I said, there was a roughly 4.5–5% benefit from extending therapy. And here, even though it's a smaller subgroup of patients with 250 patients, again, a 4.5%, so suggesting that it's representative of the larger trial. However, when you subset the trial according to H/I scores of low versus high, you can see that there was absolutely no benefit for the patients who had H/I low ratios, whereas there was a nearly trebling or quadrupling of the benefit for the patients who had an H/I high score. Put another way, all the patients that were likely to benefit from extension of endocrine therapy had H/I scores that were high. And on the right, you can see that if you do the math, this is a hazard ratio of 0.35, a relative risk reduction of 65%, and a statistically significant p-value. So this got the ball rolling. This is the first, but they didn't rest on their laurels. They wanted to make sure that this was a robust finding in a variety of different settings. So this takes me to TransAtom. So recall, this is a trial with almost 4,000 patients. Patients may have been on tamoxifen and then were randomized to either stopping or extending for another 5 years with more tamoxifen. So this is what I call TAM after TAM. So that was the parent trial. In the sub-study, I'm showing you here the 790 or so patients that had node-positive disease. They actually looked at this in the node-negative setting within this trial as well, but there were so few events in that study from the node-negative group that we really couldn't apply the test to that. So here, for the moment, we're just focused on the node-positive patients. And again, for the parent study, there was roughly about a 4–4.5% improvement for continuing tamoxifen for the full 5 years. And in this sub-study, in the node-positive subset, you again see a roughly 4% improvement for this group of patients, suggesting that this smaller group is representative of what was observed in the larger trial. However, when you subset these patients again based on H/I, the H/I low score, there was no benefit. Actually, it tips down. It's in the negative territory. And really all the benefit observed for these patients was in those patients who had H/I high scores, a really 9.7% improvement there. When they did the math here, you get a relative risk ratio again, suggesting a 67% improvement, a hazard ratio of 0.33, statistically significant, and importantly, in the H/I low group, no such observation was made, so suggesting that that group really doesn't benefit. And then ideal. This is a little bit more contemporary to how we might manage our patients. I'll just make one caveat about the parent study, which was a 2,000 patient study. Generally speaking, compared to a lot of the studies like NSABP42, this is a higher risk group. Many of the patients had seen chemotherapy, and the investigators at the time of designing this trial felt compelled to offer some amount of extension of therapy. So here you have patients who may have seen tamoxifen, aromatase inhibitor, or that commonly practiced switch strategy with TAM followed by an AI. After they finished those 5 years, then they were invited to be randomized on this trial. But here, instead of having 0 years, there was a 2.5 year versus a 5 year. So the full duration of therapy is 7.5 versus 10. In the parent study, there was actually no observed benefit for extending in this trial. In the subset of patients here, you see a 4.9% difference, but again, it's not statistically significant. When they subsetted this patient further based on H/I low versus high, the low folks, again, no benefit, and the high group, you see a 9.8% difference between the two. So a doubling, and really all the benefit to be captured in this study was in those patients there. When they calculated the hazard ratio here, it's 0.42, 58% relative risk reduction, a statistically significant p-value, and no observation of that kind in the H/I low group. Because this is a contemporary study, we were really curious what happened to the patients who had any exposure to an AI. So this is a subset of the prior slide with the 800 or so patients that had seen any amount of aromatase inhibitor use. Here you're seeing a nearly 6.1% difference for the 794 patients in this subset. But when you again subset that patient group further into H/I low, no benefit observed, H/I high, a nearly 12% difference between the two arms. Calculating, crunching out the numbers here, the hazard ratio is 0.34, suggesting, and again, a 2/3 relative risk reduction. And in the H/I low group, no benefit was observed again. So very consistent with what was observed in the other studies. And then finally, probably the hardest study to understand, but we'll go through this carefully. NSAB42, this is the parent study, not the subset. Roughly 3,900 patients, done in the United States and Canada, very, very similar to the patients that many of us will take care of. Patients could have been on an aromatase inhibitor for 5 years. Patients could have been on tamoxifen followed by an AI for 5 years. At that point, they were invited to be randomized on this study, 5 years of extension with an AI versus placebo. And for the overall study, for the outcome of disease-free survival, which includes a lot of different outcomes, 3.3% difference, statistically significant. But by being a statistically significant finding, you can then look for other outcomes. And here they looked at distant recurrence specifically, a very modest 1.8% difference there, statistically significant, roughly 28% relative risk reduction. But the way to properly express this is that out of every 50 patients, one was benefited for a distant recurrence event. So a few caveats about this study and understanding the translational cohort. There's a couple different phenomena that play out, but one of the most important is that when you looked at the post hoc analysis compared to the ideal trial, which had a higher risk patient population, they had 88% power to really see BCI operationally be successful. Here in this trial, it's only 50%, so it's underpowered. In addition, and this is something we observe in a lot of studies of extension of endocrine therapy, as these cells are being treated in the adjuvant setting, they're essentially being programmed into dormancy and they're just hanging out. And the minute you stop the endocrine therapy, it's not as if all these cancer cells just suddenly wake up and become active. That reprogramming to become productive cancer cells again takes some time. And so as you start these folks on placebo versus continued endocrine therapy, those differences about the effect of starting that endocrine therapy or keeping that endocrine therapy or discontinuing it, they don't play out for several years. We saw that in ADAM, we saw that in, and now we're seeing this in B42 as well. So there's nearly a 4-year time period before the curves actually start to separate. So when you're doing a translational study like this, you have to correct for that. You have to account for that. And so you can see when they do that and they apply that BCI H/I high versus low index, it's really after those 4 years after you've made that correction where you can see a difference, and you can see that in the two plots. And this is specifically for distance recurrence. So this is the meaningful endpoint that many of us care about. So put another way, hazard ratio with those corrections made, hazard ratio of 0.29, suggesting a 71% relative risk reduction for the group that it was extended on AI, and no such observation for the H/I low group. I know that is complicated. It's almost unfair because you almost understand something you thought you understood, but it's important to actually go through that very carefully so you know how the test works.